आज क्या केस है देखते हैं, उसके साथ ही करूंगा।
9 o'clock स्टार्ट होगा। यार जल्दी होता है 7 o'clock ऐसा।
नहीं उनको 9 o'clock। तो अच्छा है ना। ये चालू आपको कैसे समझा चाहिए तो चालू ओके ग्रुप पर
इधर शॉर्ट बैग क्या सकते हैं।
जाओ आ जाओ ना।
नहीं डालो तो मैं चेंज
नहीं कर सकते हो। आपको चाहिए क्या? चाहिए क्या आपको? अरे सर
गुड इवनिंग गणेश। यार क्लास
गुड इवनिंग
क्लास
अमनदीप को लिंक भेजा था क्या? मैंने नहीं भेजा था सर।
नहीं, तन्वी ने भेजा है, मैं उससे
Okay.
उसके साथ बात भी किया है, पर
No
अगेन
problem.
आई जस्ट
मैं
आस्क
फोन
तन्वी।
करता हूँ उसको।
Sir,
हाँ
I've just joined.
क्या अमन, आराम से।
Amandeep, so nice to see you.
I've spoken to Dr. Amandeep, sir. He will
नहीं, he has
be
joined.
joining.
Tanvi has joined.
Yes.
Okay.
Amandeep,
Amandeep,
you
thank you
remember?
so much for joining today.
Yeah, so
Right.
Ganesh, I want you to introduce him, okay?
Yes.
And
चालू कब करना है अभी?
just let little 5-7 minutes, people will join, our students,
ठीक है।
they join in about 9:95. So then we
अमनदीप
will
तू एक
start.
लस्सी पी के आ।
Amandeep, you remember 1 year back when you had presented this, I had told you
Yes, I remember that. It was in Goa.
Goa or it was in Bangalore?
Eurocosmos was in Goa, no, sir, last year. That is
Acha,
where.
okay.
Yes.
There you presented. Fine.
Yes. Sir, I'm well audible, right?
Yeah. Well audible. And uh, you want to run your slides also, correct?
Yes, sir.
आज महेंद्र का है।
Sir, I'll just share my screen to see if it is all okay. I'll just.
Okay.
Yeah.
Is it seen?
We can see.
Yes, we can see it.
Sir, you are host. Please make co-host who is presenting.
Okay.
Okay, sir. Are the slides also changing?
Changing.
Okay. All right.
Patience. Patience. So, Sohail, you are answering today?
Sir, me, Dr. Rupam, I am answering today, sir.
Rupam, you are answering today?
Yes, sir.
Okay. And who else is there, Sohail?
Who is presenting today? Amandeep, you are presenting?
Yeah.
Yes, sir. Yeah.
Okay, okay. And Srishan? Sri Ram, sorry.
Yes, sir. Good evening, sir.
Good evening. Good evening. I think we have to wait. Badwe sir, good evening. Welcome.
Dr. Badwe, welcome for our clinic.
Thank you. Thank you. I have come here for Amandeep Arora.
Very
Yes.
good, sir.
अमनदीप कभी आ रहा है? अमनदीप का बाद में है क्या? चलो क्या बात है अमनदीप? Dr. Badwe here.
Hello, good evening, sir. I am flattered.
How do I entrust
Hello. Let's listen to Amandeep.
वीडियो नहीं करो ना खाली.
Good evening, sir. Welcome.
But they know I joined. Yeah, welcome, Shikhan Badwe. Mute चाहिए, अनिकेत mute के लिए. Participant 40. हाँ, आयुष. मैंने ऑन करवाने के and participants I am I'm so double. That's another.
Mahendra, welcome. Okay. I think we can start now.
Mahendra,
Good evening,
welcome.
sir. Yeah. Good
Mahendra,
evening, sir.
Dr. Badwe here.
Yeah, good evening, sir. Good evening.
Good evening. Hi. I think we'll start. Sir.
Let us start, sir. Mahendra and Ganesh bhai both are there.
Again, चालू करते हैं. So today,
Yes, yes. Let's start, sir.
our topic is metastatic prostate cancer.
Yeah.
And we are initially having a kind of a comprehensive presentation. Amandeep is professor of uro-oncology and well known to all of you. He teaches very well. The feedback from Dr. Gaurang Shah, and we had to request him to be here. The only other request is if you like to be that you can join even other times in case you are. There's a lot of students here who some people who are working at a very grassroots level and have a large experience. Who comes here every Tuesday. So thank you so much for accepting this. Gaurang Shah and Dr. sir, who have started. As you know, Tanvi follows this program. So I think let's not waste time in begin. A lot of people who especially over to you, Amandeep. You share your presentation and start.
Yes, sir.
Thanks.
Okay. Firstly, it is a matter of great honor for me that my teacher is introducing me. Whatever I know, whatever I'm speaking, whatever I know in oncology has all been taught by Bakshi sir, Mahendra Pal sir, and the fact that I have the good fortune of working in this prestigious institute, Tata Memorial Hospital. I thank Gite sir and Gaurang Shah sir and the other organizers for inviting me to speak here. I have been listening to these talks even when I was a student, which was not a long time back ago. And I've been asked to speak on metastatic hormone-sensitive prostate cancer. I hope I'm well audible because I don't think I could hear Bakshi sir too well.
You are audible. You are audible.
Okay, all right, sir. All right. So this presentation is rather in the form of a case capsule, ideal for a panel discussion. And, but we are not doing a panel discussion because it gets a little cumbersome to do a panel discussion over a Zoom meet. And I thought I'll ask the questions and also give the answers on my own so that we cover a lot of topics in the allotted time. So this is our patient, 71-year-old male, routine standard patient, ECOG 1, no significant family history, and no comorbid illnesses. He had voiding LUTs since a year. He also needed a catheter 2 weeks back, and we'll come to that later. On the digital rectal examination, he has a grade 3 hard nodular prostate. His PSA comes out as 254. Now, when we have somebody who has LUTs, who has an enlarged prostate, and who has a raised PSA, the next thing that we want to do is a prostate biopsy. But do we want to do an MRI prior to the biopsy? Why do we want to do an MRI prior to the biopsy? A, in some patients, after seeing the MRI, we can avoid the biopsy. B, in some patients, we can see a lesion on the MRI and then we can get targeted biopsies from the prostate. And C, it gives us the T staging for the prostate cancer. Now, all this is applicable to patients who have borderline raised PSA. Our patient has a PSA of 254. In this patient, we are not expecting or anticipating that he has localized or locally advanced prostate cancer. We are mostly thinking that this patient already has metastatic prostate cancer. And thus, all these 3 points that I told you about why we would want to do an MRI prior to the biopsy are not valid in our patient. And that is why in our patient, we would not want to do an MRI prior to the biopsy. Now, what if the PSA of this patient was 25 instead of 250? Then we would have definitely done an MRI prior to the biopsy, despite the grade 3 hard nodular prostate, because we would want an accurate T staging, and we would also want to get targeted biopsies from the prostate. Can we do the MRI after the biopsy if the PSA is 25? Yes, we can, but then we would have to wait at least 4 to 6 weeks to get an accurate assessment of the T stage of the prostate cancer. And that is why it is always advisable to do an MRI prior to the biopsy in patients with borderline raised PSA, in whom you are suspecting that they might have prostate cancer, which is non-metastatic. How many cores would we take in our patient who has 256 PSA? So in our patient, we are not wanting to take a systematic 12-core biopsy. We are not wanting to take targeted cores from a suspicious lesion seen on the MRI. In this patient, we just want to prove that this patient has prostate cancer. And for such a patient, limited number of cores is what is to be taken. How many limited is not defined. We usually take 2 cores from each lobe, so around 4 cores of the prostate biopsy. So in our patient, when the biopsy was done, it came out to be adenocarcinoma prostate with Gleason 4+5. That is all the information that we want to know from our patient. We don't want to know how many cores were positive. We don't want to know how many cores were taken. We don't wish to know the percentage of core involvement. We don't wish to know how much Gleason 4, how much Gleason 5, whether there is LVI, whether there is PNI. All that we want to know is whether he has adenocarcinoma prostate or not, and our biopsy has said that he has it. Now, what is the evidence for doing the MRI prior to the biopsy? Now, this is not valid for our patient, but these are the 4 large trials and studies which have shown that you do an MRI prior to the biopsy in patients with borderline raised PSA. So patients in these trials had marginally raised PSA, only up to 15, and very few had an abnormal DRE. And that is why those 3 things that I told you: 1, not do a biopsy for a patient; 2nd, identify a lesion in targeted biopsies; and 3rd, get an accurate T staging for the prostate cancer are the indications or are the rationale why we do an MRI prior to the biopsy. So the guidelines say that you perform an MRI before prostate biopsy in men with suspected organ-confined disease. And they also go on to say that in men with suspicion of locally advanced disease on DRE and a PSA of more than 50, or those for not curative treatments. Our patient probably has metastatic cancer. He's not for curative treatment. Our patient has a PSA more than 50. In such patients, guidelines say consider limited biopsy without the MRI. And that's why we did not do the MRI prior to biopsy for our patient. Now, once we had proven that our patient does have prostate cancer, the next investigation that we need to do is to stage the patient to find out the N and the M staging. So the guidelines say that we need to perform PSMA PET CT if available and at least cross-sectional abdominopelvic imaging and a bone scan. So the wordings of the guidelines have been changing in the last few years. A couple of years back, they would say that you can either do a PET scan or do a CT plus bone scan. But now, the wordings are suggesting that if available and if possible, the guidelines also kind of hint towards saying that you do a PSMA PET CT. If it is not possible to do a PSMA PET CT, you might as well just do a CECT A plus B and a bone scan for accurate staging of the patient. Okay, now what if a CT and a bone scan has already been done? So the patient comes to you with a CT and bone scan already done. Would you still do a PSMA PET CT in this patient? Now, there is no yes or no or a black and white answer to this question. The thing is, this patient is going to be put on some therapy, and you would want to monitor this patient on the therapy later on to see the disease response. And at that time, you would surely do a PSMA PET CT in this patient. Hence, if affordability is not an issue, we would always want to have a baseline PSMA PET CT. Even if a CT scan and a bone scan has been done, it is not going to mostly alter our management right now. It is probably just going to give us a more accurate baseline staging over which our future PSMA PET CTs will be compared. If the patient is not affording for another PET scan, we can definitely skip it if he has a CECT, abdomen plus pelvis, and a bone scan. So why am I saying that you do a PSMA PET CT? Just concentrate on those numbers on the slide. The sensitivity and specificity of the PSMA PET CT for nodal and distant mets is much higher, in the high 90s compared to a bone scan. And also please read this line: marrow or lytic skeletal metastases are missed by a bone scan. Your bone scan picks up only osteoblastic mets, which are very characteristic of prostate cancer, but sometimes prostate cancer can have marrow mets and lytic mets, and they will not be picked up by the routine bone scan. One word of caution here is that we will read this line: all prospective data available, that is all the trials that we have available, Stampede, Latitude, Charted, and all of those, they rely on the definition of metastatic disease based on CT scan or MRI and a bone scan. Hence, the influence on treatment and the outcome of newer imaging has not yet been assessed. So we would want to do a PSMA PET CT in our patients, but whether this impacts their management, whether this leads to a better survival for them, is something that we do not know as of now. Now, what if an FDG PET CT had been done for the patient? So we would want to do a PSMA PET CT for our patients because PSMA is the tracer that is very specific for prostate cancer. Prostate cancer usually is not picked up on an FDG PET CT. The reason being that FDG PET CT picks up lesions in the body which are hypermetabolizing, which are using glucose. Prostate cancer is a very slow growing cancer, and that is why the dividing cells don't use up glucose to such a fast extent, and that is why prostate cancer lesions are not seen on an FDG PET, and that is why an FDG PET CT is not advised in a patient with prostate cancer when you want to stage the patient. So if somebody has come to your OPD with an FDG PET CT done, we would want to do a PSMA PET CT in this patient. Would we want to do an FDG PET CT if the biopsy has a neuroendocrine component? So sometimes when you have a very high Gleason score, like a 4+5 or a 5+4 or a 5+5, those 9 and 10 Gleasons, sometimes they can have a neuroendocrine component of prostate cancer also in the biopsy. It takes a very experienced pathologist to pick this up. And if the neuroendocrine component is picked up, and if the suggestion is that there is a considerable neuroendocrine component in the prostate biopsy, then we might want to consider doing an FDG PET CT in that patient, because FDG PET CT is more specific for the neuroendocrine component as compared to the PSMA PET CT, which is more specific for the adenocarcinoma component. Now, about 5% of our patients are PSA non-secretors, which means that they might have a lot of disease burden. They might have a very high Gleason on their biopsy, but their PSA is not very high. So their PSA is around 5-6. So in such a patient, what kind of scan should we be doing? Should we be doing a PSMA PET CT only if the PSA is very high? No. Even if in these PSA non-secretors, PSMA PET CT is the investigation of choice over an FDG PET CT or a CT plus bone scan. Now, once we have made the diagnosis that our patient does have metastatic prostate cancer, the next thing that we need to do is stratify hormone sensitive prostate cancer. And this is done by determining the volume or the burden of disease. Do we also take into account the non-regional nodes? So the regional nodes of prostate cancer are the pelvic nodes, common iliac nodes onwards. So common iliac nodes are also metastatic nodes. It comes as M1A. So common iliac nodes, retroperitoneal nodes, and all other nodes in the body are non-regional nodes for prostate cancer. If any of these nodes are positive, the M staging assigned is M1A. The patient can have n number of nodes positive on a PET scan, but this patient would still be called low volume disease. I'll tell you why. And do we use the term oligometastatic prostate cancer? So usually we do not use this term. This term has variable definitions in literature. Some say up to 4 mets, some say up to 5 mets, some say axial skeleton, some may include one from the appendicular skeleton. It is best to avoid using the term oligometastatic prostate cancer. In case you want to refer to your patient to as oligometastatic prostate cancer, the better term that you would want to use is low volume prostate cancer. This is the definition that we use, standard definition given by the charted trial. So high volume disease is 4 or more bone mets, including 1 or more bone met outside the vertebral column or the pelvis. So that is the appendicular skeleton, and or visceral mets. Okay. And if the patient has none of these, then the patient has low volume disease. There was another trial, the Latitude trial, which gave us high risk disease and low risk disease. That thing had different definitions. We do not use those definitions while risk stratifying hormone sensitive prostate cancer patients. We only use the charted definition of high volume and low volume. Now you will see here that nowhere do they speak about nodal mets. That is why I told you that a patient may have 10 nodes positive, but if he has 0 bone mets, this patient would still be called low volume prostate cancer, metastatic prostate cancer. Now again, this definition was given by a CT plus bone scan, but today we risk stratify our patients for their volume based on the PSMA PET CT. So how is all this valid? We still don't have an answer to it, but still we manage our patients according to the PSMA PET CT volume. Now, one more question is, if somebody had that PS of 254 and a PSMA PET CT was already done, which showed that the patient already has florid mets on the PSMA, would we still want to go ahead and biopsy this patient? The textbook answer or the guideline based answer would be yes. However, we from Tata Hospital had presented this paper in 2018 at AUA. We'll read this. In patients with high clinical suspicion of metastatic prostate cancer, PSMA PET scan can be done prior to doing a biopsy was our conclusion. An unequivocal PSMA uptake in prostate and metastatic sites along with high PSA levels reliably confirms diagnosis of prostate cancer and has the potential to obviate the need of biopsy in this group of patients. This might or may become our practice in the future, where we do a PSA. If it is very high, we straight away do the PSMA PET CT. And in patients with florid met, we might not biopsy because it is not really impacting our treatment unless we want to also look for a neuroendocrine component in them. Coming back to our own patient. So our patient had PSMA expressing metastatic pelvic lymph nodes. So he became N+, and he also had PSMA expressing metastatic retroperitoneal lymph nodes. So he became M1A. He did not have any bone mets, and that is why our patient was classified as low volume, hormone sensitive, metastatic prostate cancer with a Gleason of 4+5 and an initial PSA of 254. Now our patient's PSA was 254. Does a comparatively low PSA worry you? So what we've seen in the clinic is there is no real literature for this, but what we've seen is PSA non-secretors, they do not do so well with treatment. So somebody having lots of mets but a relatively low PSA would be a little more worrisome than somebody having lots of mets and a high PSA. And also, if somebody has a low PSA with a lot of mets, I would want the pathologist to have a more stringent look at the slides to see if they can pick up something other than only adenocarcinoma prostate in the patient. One thing that they might pick up is neuroendocrine cancer. These are some features of neuroendocrine prostate cancer. Visceral only. I think. Yep. So visceral only mets are more common with neuroendocrine prostate cancer, multiple meds with no PSMA uptake, and that is why you'll pick up those meds with an FDG PET scan as we spoke earlier. And you will see rapid progression after an initial response to ADT, because the initial response came about because the adenocarcinoma component responded to ADT, but then the neuroendocrine component has not yet been treated, and hence there will be rapid clinical progression for the patient. Is a low PSA an indicator of poor response to androgen deprivation based therapy? Again, we don't have an answer to this, but common sense or logic might suggest that somebody who has a considerable neuroendocrine component and has a low PSA with a lot of meds is not going to do so well compared to a patient who has a higher PSA. So now coming to our treatment. So the first thing that we want to do for our patient is androgen deprivation therapy. We have these options available: orchidectomy, agonists, and antagonists. Now, how do we decide? We decide based on some patient factors like the performance status of the patient, when we decide whether we want to do a surgery in him or not, whether the patient is on blood thinners which can be stopped or not, whether the patient has some cardiac history, which we'll see again later, and what are the financial aspects for the patient, because androgen deprivation therapy is no longer the only treatment for the patient. Patients need to take chemotherapy, some more drugs, some bone protecting agents. Hence, they need to save some finances, and the only place where they can save some finances is where they opt for an orchidectomy over the injections, because an orchidectomy is a one-time expense. And we also decide based on some disease factors whether the patient has an impending cord compression or severe voiding LUTs, where we would not want to give him an agonist. Now, this was a seminal paper by Charles Huggins in 1941, which laid the foundation of androgen deprivation therapy for prostate cancer. The paper said that prostate cancer is influenced by androgenic activity, and disseminated or metastatic prostate cancer is inhibited by eliminating androgens by castration. And this paper laid down the foundation of hormonal manipulation of prostate cancer, and it's been close to 85 years that we are still doing this. And this is the first step that we do for any patient with disseminated prostate cancer. Let us have a quick look at the androgen pathway. So in the body, from the hypothalamus, the gonadotropin releasing hormone is secreted, which then goes and acts on the pituitary and asks the pituitary to release FSH and LH. The LH goes and acts on the testis, where testosterone is produced, and then the testosterone goes and acts on the androgen receptors at various metastatic sites in the body. What are the options that we have to stop this? We have GnRH antagonists like degarelix, which will completely stop the production of GnRH from the hypothalamus.
I think please mute yourself, everybody. There are too many students who are loose enough to keep their speaker on. It is not so difficult.
Okay, so we have GnRH.
Mr. Veku. Some Mr. Veku is there. He is not on mute.
जो कोई host है ना, just remove that person.
Exactly.
And this should be the rule from here on, I think. If they
Yes,
are not
sir.
interested, they should not join.
Agreed, sir. Please go ahead, Amandeep, sir.
Yes, sir. So we have GnRH agonists like leuprolide, triptorelin, goserelin, which will suppress the production of FSH and LH from the pituitary after an initial rise, obviously. We have orchidectomy, which will lower the production of testosterone from the testis, and then we have anti-androgens that will go and actually act on the receptors. This is bicalutamide, enzalutamide. So this is the way in which we try to manipulate the androgen pathway in the body. So the first thing is bilateral orchidectomy. So the rationale is that 95% of testosterone is produced in the testis. The advantage is that this is the fastest way to reach castrate levels, and within 6 to 12 hours, the testosterone level is to castrate levels. Very economical, one-time cost to the patient, and it can even be performed under local anesthesia if the patient is not fit for a short GA. The disadvantages are that some patients may not be psychologically willing for a permanent castration. An occasional patient will land up with a wound infection or a scrotal hematoma. In patients with some psychological issues of not having an orchidectomy, you may try a subcapsular or an epididymis sparing approach in them. Coming to GnRH agonists, so the mechanism of action is that they cause a sustained increase in the level of GnRH in contrast to the physiological pulses that occur in the body. The sustained release eventually leads to a downregulation of GnRH receptors in the pituitary, and that is why the pituitary stops releasing FSH and LH. Here, LH is of more importance to us. The initial increase in the GnRH because of the sustained increase causes a flare phenomenon which lasts for 15 to 20 days, and that is why we give these patients bicalutamide 50 mg once a day for 3 to 4 weeks to cover the flare, and castrate levels are achieved in 2 to 3 weeks. So it is much slower acting than orchidectomy. Various formulations are available in the market. We have the three main drugs, leuprolide, triptorelin and goserelin. And the annual cost comes to around 40 to 60,000 rupees because you require an injection once every 3 months. What about GnRH antagonists? So the mechanism of action is that they cause a suppression of the GnRH levels from the hypothalamus. So there is a decrease in the production of LH and FSH from the pituitary. There is no flare phenomenon here. LH levels fall by 84% within 24 hours. Castrate level is achieved in 90% patients within 10 days. So it's again faster than the agonist, not as fast as the orchidectomy, but pretty fast. Injection site reactions are known. This injection is given subcute on the abdomen. The dose is also significantly high, especially for the loading dose, and patients can sometimes have injection site reactions. The loading dose is 240 mg, maintenance doses of 80 mg monthly, subcute administration, and the annual cost comes to around 1.5 lakhs in the first year, mainly because of the loading dose, and then it is 1 lakh per year for the maintenance doses, which is one injection taken every month. Recently, an oral antagonist, relugolix, was also approved, and this is now available in India and costs around 10,000 rupees for a month. So again, around 30,000 rupees for 3 months. Now, what is the cardiovascular risk with agonists? So the agonists, that is leuprolide, triptorelin and goserelin, they lead to an increase in LH and FSH. Although it is transient, but they do lead to an increase in LH and FSH. And the increased FSH has been postulated to lead to plaque rupture and cardiovascular events. So LH was more important for causing cancer, and the FSH is more important when we're talking about plaque rupture and cardiovascular events. This risk is especially higher in patients who already have a history of cardiovascular events. Now you might say that orchidectomy, because you are removing the testes, now testosterone is not being produced, so the body will produce more of LH and FSH, and hence orchidectomy should also have cardiovascular side effects. The thinking or the logic is correct. The problem is that orchidectomy is mostly done in the lower middle income countries, and all the research about cardiovascular risk comes from the high income countries or the West, where they do not do so much of orchidectomy, and hence the cardiovascular risk with orchidectomy is not very well known in literature. What we know is that agonists fare worse compared to antagonists in patients who already have a CV risk. So this is just one paper which I'll quickly show you. We'll just read the conclusion. Men with no pre-existing cardiovascular disease at baseline, there is no difference in the incidence of cardiac events, whether you used an agonist or you use an antagonist. But men who have a pre-existing cardiovascular disease at baseline, there are significantly fewer cardiac events in patients getting antagonists compared to agonists. So if my patient has a significant cardiac history, I would probably give this patient an antagonist, obviously if this patient can afford it. What are the other options that we have available? We have bicalutamide monotherapy, 150 mg OD. So when bical is used along with an agonist to cover the flare phenomenon for 3 to 4 weeks, the dose that we give is 50 mg once a day. When bicalutamide is used as monotherapy, the dose is 150 mg OD. It is not given as 50 mg TDS, it is given as 3 tablets to be taken at once. It was used in the past, but it is not recommended now. Ketoconazole and Honovan are also drugs that are available and could be tried in later settings when the patient has gone into CRPC and nothing else is working, or the patient is not affording anything, but not as the first treatment that we do for our patients as of today. So when we have these three options, which modality will you choose? Orchidectomy, agonist or antagonist? So in patients with vertebral mets with impending cord compression, because we want rapid castration to be achieved, we would either do an orchidectomy or an antagonist. When you have a large gland with severe voiding LUTs, again to prevent the patient from going into retention, we would either do an orchidectomy or an antagonist. If the patient has a high risk of cardiovascular events, again, prefer the antagonist over an agonist. Over the orchidectomy also, it is not well known. If you have none of the above factors, you decide based on the affordability of the patient. One word about intermittent ADT. So intermittent ADT is usually not practiced unless the patient is having a lot of side effects to the ADT. and the patient has a good disease profile. So if you feel that you can pause the ADT for a few months to allow the side effect profile to recover without worrying too much about the disease and the PSA level, you might try intermittent ADT. But as a standard of care practice, continuous ADT is given to our patients. Anyways, if the patient has undergone an orchidectomy, there is no question of having intermittent ADT. Do you need to cover with bicalutamide switching from degarelix to agonists? Ideally, no, because long-term degarelix has already caused the agonist levels to also go down. So a flare phenomenon is not going to happen there. Any role for a combined androgen blockade? So a combined androgen blockade is when you use bicalutamide along with an agonist. This was again used in the past. We don't use it now. It is used only when we want to cover for that flare phenomenon, but after 3 weeks, we stop the bicalutamide and cover and continue only with the agonist. So a combined androgen blockade is not recommended as of today. How common are the side effects? The side effects mainly are hot flushes, and they do occur in about a third of the patients, and they might get very severe in about 1/10 of the patients. And how do you manage them? You give them megestrol acetate 40 mg, you may try venlafaxine, duloxetine, or even pregabalin, or in a highly motivated patient with not a very bad disease, intermittent ADT if the patient has not had an orchidectomy. So now our patient, to revise, was 71 with this PSA, with this Gleason, with low volume metastatic disease on the PET scan, and we did a bilateral orchidectomy for him. Now, is that the end of treatment? About 10 years back, that would be the end of treatment, and we would ask the patient to just remain on PSA based follow-up. But as of today, this would be incomplete treatment, and we need to give something called as add-on therapy. Now, what are the options available for add-on therapy? We'll see them. How do we choose one? We'll also see that. So the first option that we have is docetaxel. Now, these are the 3 trials, Stampede, Charted, and GETEC 15, which proved that ADT plus docetaxel is better than ADT for overall survival in patients with metastatic prostate cancer. The dose is 75 mg per meter square. 6 cycles were used in Stampede and Charted. 9 cycles were used in GETEC. Usually we give 6 cycles to our patients. Benefit was seen only in high volume patients in the Charted trial, but in all patients in the Stampede trial. Hence, docetaxel was used for all patients with metastatic prostate cancer. Although recently we use it only in high volume patients and not in low volume patients because we have other options available. And docetaxel is probably the most toxic of all the options that we have available. Hence, for low volume HSPC, ADT plus docetaxel is hardly ever used nowadays. The cost comes to around 15,000 rupees per cycle, including the drug and the daycare admission charges. The second option that we have is abiraterone. Now, this is the steroid synthesis cycle that we study in physiology. I don't want you to read this. What I want you to see is, so this is happening in the adrenal gland, okay? That is the enzyme that abiraterone is inhibiting, 17-alpha-OH and 17-20 lyase. So these 2 enzymes are inhibited by abiraterone. So if 17-20 lyase is inhibited by abiraterone, testosterone is not going to form, and that is what we want. So when we saw the orchidectomy slide, we read that 95% of the testosterone in the body is produced in the testis. The remaining 5% comes from the adrenal glands. So if we stop this enzyme 17-20 lyase, this cholesterol is not going to get converted to testosterone. That is what we want. But because abiraterone also inhibits this enzyme, which is 17-alpha-OH, it also leads to reduced cortisol in the body. Because cortisol and testosterone are not getting formed, it leads to increase in aldosterone in the body. And that is why we give 5 mg of predni along with abiraterone so that cortisol levels remain high in the body. So these were the 2 trials, Stampede and Latitude, which again checked ADT plus abiraterone versus ADT alone, and they showed that ADT plus abiraterone is better for overall survival. The dose is 1 gram once a day on an empty stomach along with 5 mg of predni, and I told you why we need to take predni. Empty stomach is very important because diet can interfere with the pharmacokinetics of abiraterone. Low dose abiraterone like 500 mg has been tried, but the standard dose is 1 gram. 500 mg along with a fatty meal has been tried, but 1 gram on an empty stomach is what is recommended. The benefit is seen irrespective of low or high volume disease. So ADT plus abiraterone is standard practice for all newly detected metastatic prostate cancer patients as of today. The specific side effects are hyperglycemia. Why? Because you're giving predni. Water retention. Why? Because we saw that aldosterone was increasing in that chart, and aldosterone would cause water retention and also hypokalemia. Lipid disturbances and LFT derangements can also happen with abiraterone, and that is why LFTs need to be monitored. The cost comes to around 10,000 per month. So this is a comparison of the two main options that were used till recently. This is how we would choose. For a poor ECOG patient, because we would not want to give toxic chemotherapy, we would choose abiraterone. The duration of treatment is favorable for docetaxel because you stop after 18 weeks, whereas abiraterone is continued till disease progression. And with continued use comes continued cost and continuous toxicity. The cost, obviously, abiraterone is more expensive. For a diabetic patient, because if we are giving predni along with abiraterone, we would want to use docetaxel in an uncontrolled diabetic. In a controlled diabetic, predni with abiraterone can very safely be used. If somebody has renal failure, we cannot give cytotoxic chemotherapy, so we would not want to give docetaxel. Abiraterone has hepatic excretion in the body. So if somebody already has hepatic insufficiency, we would not be able to use abiraterone in that person. If somebody has uncontrolled hypertension, again, using abiraterone causes water retention, could cause hypertension, could worsen the uncontrolled hypertension. We might want to use docetaxel in such a patient. What is the third option that we have? We have enzalutamide. These are the trials, ARCHES and ENZAMET. The dose that we use is 160 mg, so it's available as a 40 mg tablet. 4 tablets are taken once a day. Some patients in these trials, ARCHES and ENZAMET, had received both enzalutamide plus docetaxel. So the trial was, the standard arm was ADT and the intervention arm was ADT plus enzalutamide. Some patients in the intervention arm also got ADT plus enzalutamide plus docetaxel. So triplet therapy was also used in the intervention arm. Specific side effects of enzalutamide are cognitive disturbances, a propensity to fall, and fatigue. And somebody who is already prone to seizures, we would not want to use enzalutamide. The cost, a little more expensive than abiraterone, comes to around 15,000 rupees a month. The fourth option that we have is apalutamide. This is the trial, Titan trial, which showed that ADT plus apalutamide is better than ADT alone. It is now available in India. The dose is 240 mg once a day. It is usually well tolerated, but a skin rash can be a specific side effect. It is the most expensive of the 4 options that we have. It comes to around 25,000 per month. This is one table which is showing these 4 agents, and we've mostly gone through all of it. Yeah, so I'll probably be sharing the slides so you can have a look at this table later on. Now, we always read that there is some concern for, how do we use? Do we first use abiraterone? Do we first use enzalutamide? Does one work better than the other after one has been used? So there is a very simple logical answer to this. What is abiraterone doing? Abiraterone is reducing the production of testosterone from the adrenal glands. What is enzalutamide doing? Enzalutamide is going and acting on the receptor and blocking the receptor. Okay. Now, if you have used abiraterone, and the cancer then progresses, which means that you stopped the production of testosterone in the body, but the cancer still found a way to cause activation of the receptor. So then you can use enzalutamide, which will go and block the receptor, and the cancer will stop progressing. Now, see the other scenario. If you have used enzalutamide before, so you have blocked the receptor, and now the cancer starts progressing, which means that the cancer no longer depends upon testosterone, no longer depends upon the androgen receptor. It has found some new way of progressing. So now, even if you lower the level of testosterone in the body by using abiraterone is not going to work, because that cancer in the body because that cancer in the body has found some other way of growing. So that is why ADT plus abiraterone should be our first agent of choice, because every patient with metastatic hormone sensitive prostate cancer is going to become metastatic castrate resistant prostate cancer in due course of time, and you would want to have enzalutamide as an option available when the patient progresses. Because if you've used enzalutamide in the first setting, there is probably no use of using abiraterone when the patient progresses. So unless a patient has very strong contraindications to using abiraterone, ADT plus abiraterone should ideally be the first agent that you use, so that enzalutamide is still available for backup. Now, what are the investigations that we do? The investigations basically depend upon what side effects the agent can cause. So when you're using docetaxel, you would want to monitor the RFTs and the CBC because it is cytotoxic chemotherapy. When you use abiraterone, you would want to see the LFTs and the electrolytes. Now, if the patient had a 5+5 Gleason and also a neuroendocrine component, along with these agents, our medical oncologist would probably want to give the patient etoposide-based chemotherapy because neuroendocrine component would not respond to any of these agents that we have used. And the threshold for giving that etoposide-based chemotherapy will depend upon the component of neuroendocrine cancer in the biopsy. So again, comparing these 4 agents that we saw, this is the hazard ratio for overall survival. So as you can see, there is little to choose. So there is no clear evidence of superiority of one agent over the others. And also there is no inter-agent direct comparison also available in literature. We'll just see one more slide of comparing docetaxel and abiraterone. So abiraterone was better for PSA-based endpoints. Now what are PSA-based endpoints? So we monitor patients with PSA. When PSA starts rising, we say that the patient has failed. So progression-free survival and failure-free survival are PSA-based endpoints because we say that the patient has failed when the PSA starts rising. Now abiraterone acts on the testosterone pathway. So obviously it will lower the PSA much faster than docetaxel. And that is why abiraterone is better for the PSA-based endpoints. These. But there is no difference in the cancer-specific survival and the overall survival when you choose docetaxel and abiraterone. So abira patients remain as HSPC for longer than docetaxel patients because once the PSA rises, we start calling the patients as CRPC. So in abiraterone, the HSPC stage is longer and then the CRPC stage might be a little shorter. In docetaxel patients, because there is not such a great effect on PSA, HSPC stage might be shorter and the CRPC stage might be longer. But finally, for all these patients, whether you use abira or docetaxel, the entire duration of the patient being able to live, which is measured by cancer-specific survival or overall survival, is the same. And there is nothing to choose between the two. Now, abira scores over docetaxel in the meta-analysis because it says that the hazard ratio is 0.61 compared to docetaxel, which is 0.79. And for serious adverse events also, we say that abiraterone is probably better tolerated than docetaxel. Now, what do our patients say? Because nowadays we have a lot of papers coming out about patient-reported outcomes, PROMs. So this was a paper reported in 2022 in patients who were allocated to either docetaxel or abiraterone in the STAMPEDE trial. And what they said was patient-reported QOL was superior for abiraterone compared to docetaxel over a 2-year period. So even though patients have to take abiraterone every day for 2 years, they are probably tolerating it better than taking docetaxel just for 6 cycles. And that is why ADT plus docetaxel, especially for low volume prostate cancer, has little gone out of vogue nowadays. So we've done androgen deprivation for our patient. We've done the add-on therapy also. We've discussed that we have 4 options available, but out of those 4, we would ideally or mostly want to start abiraterone for our patient, not want to use docetaxel at all, reserve enzalutamide and apalutamide for when the patient progresses. Now, is that the end of treatment? Again, till some years back, it would have been the end of treatment. But now we also want to hit the primary. We want to hit the prostate. Why do we want to hit the prostate? Because the amount of cancer in the body is less. So we feel that there is still a lot of cancer in the organ of origin. And if we hit it hard, we might be able to prolong survival. So the rationale is that the primary is the seed, but it also prepares the soil. So you want to hit the primary. Cytoreductive nephrectomy, as we do in metastatic RCCs, also provides a proof of principle. And we have encouraging data coming from smaller series. And that is why in the STAMPEDE trial, this arm H was recruited, where we added radiation therapy to the prostate. So these are 2 curves from the STAMPEDE trial. Just look at this. When patients had low metastatic burden, what is low metastatic burden? Low volume prostate cancer, as defined by charted. So we are applying the charted definition to patients in the STAMPEDE trial, and patients who had low volume disease in the STAMPEDE trial, we can see that the p-value was significant and the hazard ratio was also significant. But when we saw patients with high metastatic burden, the charted high volume patients, we can see that the p-value is no longer significant and the hazard ratio is 1. So we concluded that adding radiation therapy to ADT in metastatic prostate cancer patients has benefit only in low volume prostate cancer patients. In 3 years, the overall survival improved from 73% to 81%. So do we give it for all low volume patients? The answer is yes. There are 2 trials. Stampede I showed you. There was another trial which came before Stampede, which was called HORAD. In HORAD, there was only progression-free survival benefit. OS was the same. So RT to the prostate was still not being used very vigorously. But once Stampede came out and showed that there is overall survival benefit, the main criteria that we want to look for in all survival trials that are done for any cancer, there was OS benefit for low volume patients, and that is why we have started using RT to the prostate in low volume metastatic prostate cancer patients. When do we give this RT to the prostate? So this is not the first thing that we want to do for our patients. We would still want to start the androgen deprivation therapy. We would still want to give them abiraterone or enzalutamide. Why? Because our patient has systemic disease. The entire body or the entire system has disease. This is local therapy. Radiation is local therapy. We would first want to give systemic therapy to the patient. We would want to give agents that are acting on the entire body. 6 months later, we've got a fair idea of how this patient's biology, how this patient's cancer is responding to the treatment that you're giving. And if this patient's PSA falls to a great extent, and we see that the systemic therapy has worked, and now the bulk of the disease is focused on the prostate, that is when we go ahead and give RT to the prostate to try to hit the primary harder. And we wait for 6 months. How much do we give? We give 72 gray in 36 fractions, and we give it only to the prostate. We don't give it to the nodes here and there. We don't give it to the pelvic nodes. We don't give it to the metastatic sites. We give it only to the prostate. Why? Because in the Stampede trial, RT was given only to the prostate. If we can do radiation therapy after 6 months, can we do prostatectomy? So there is no level 1 evidence because the Stampede trial had only RT and did not have prostatectomy. But we have numerous large single center, multi-center case series which say that prostatectomy works as well as radiation therapy in low volume prostate cancer. So is it equivalent to RT? Logically, we might be able to extrapolate, but we still don't have level 1 evidence. But we might prefer surgery over RT if our patient has significant lower urinary tract symptoms. Again, in such a patient, there is an option of doing a channel TUR and relieving the patient of the LUTs and then doing radiation therapy, which has level 1 evidence. Or we can have a discussion with the patient saying that we are doing prostatectomy because that will rid the patient of the cancer in the primary and also rid the patient of the voiding LUTs. But still, one answer to give would be channel TUR followed by radiation therapy as of today. Now, so we've given RT to the prostate as well. Now this patient has 1 or 2 bone mets. Would we want to kill them also? Would we want to give RT to the metastatic sites also? So giving RT to the metastatic sites, there is evidence from 2 trials. One is called STORM, one is called ORIOLE. But the evidence is only in CRPC. It is not in HSPC. So it is in patients who have had a recurrence of their prostate cancer in 1 or 2 bones. So these patients have already been on their systemic therapy for many years. Now their disease starts progressing and you pick up 2 lesions somewhere. You might want to give radiation therapy to those lesions so that the disease progression halts. But there is no oncological benefit of giving MDT, metastasis directed therapy, or RT to the metastatic sites in hormone sensitive prostate cancer. Okay, so we've done ADT, either orchidectomy or the injections. We've added either abiraterone or enzalutamide to our patient. We decided that after 6 months, we'll see whether we want to give radiation therapy to the prostate. And we have said that we would not want to give radiation therapy to any of his 1 or 2 bone lesions. There is something more that we would want to do for our patient, and that is called bone health. So we would want to do calcium and vitamin supplements for all of them. Would we want to do a DEXA scan in them? And what is the role of zoledronic acid? We'll just see right now. So there are 3 elements detrimental to bone health in all our metastatic prostate cancer patients. One is age-induced osteoporosis, because all our patients are mostly old. B, bone metastasis. These patients have bone mets, right? And those bone mets are eating up the bone. And C, cancer treatment-induced bone loss. Now, when you are starting androgen deprivation therapy, you are lowering testosterone in the body. टेस्टोस्टेरोन का एक ही काम नहीं है in the body to allow prostate cancer to grow. Testosterone is the main male sex hormone. It is responsible for feeling active, for uh, having good bones, having bone health. So when you lower the level of testosterone in the body, it leads to cancer treatment induced bone loss. Steroids, you're adding predni also causes osteoporosis. So all these three agents act together in our metastatic prostate cancer patients, and that is why you would want to take care of their bone health so that you avoid something which we call as skeletal related events. We do not want them to have pathological fractures. So recognizing the problem is very important. A lot of people don't prescribe bone agents. So this was a paper written in the Indian Journal of Urology 10 years back, and this is what they concluded. In a recent survey among 108 randomly selected qualified Indian urologists, it was found that a majority of them have not been following the recommended guidelines related to bone health management. What they found was, this is another paper, which asked whether, would you routinely use zoledronic acid or denosumab in your patients? And for hormone sensitive cancer, 31% said yes. And I will tell you whether we should be using them routinely or not. And for CRPC, 32% said no. When in CRPC, you should be uniformly using zoledronic acid in all patients. Now coming to the DEXA scan. So DEXA scan is easily and widely available. Any place which does a PET scan also does a DEXA scan. It is not very expensive, and that is why guidelines also recommend that before starting your patients on long-term androgen deprivation therapy, and all our metastatic patients will get long-term androgen deprivation therapy, we should do a DEXA scan to have a fair idea about the existing bone health of our patients. So the guidelines recommend that. There's a small caveat here that prostate cancer mets are osteoblastic. So they are seen as more white on the X-ray or the fluoride scan that is done, and that may give a falsely high score because the more lucent the bones are looking on the scan, it suggests osteoporosis. But you may have a bone met sitting there, and if you go and measure there, you will get a falsely high value because it is looking more opaque and not looking lucent. Now, what is the intent here? So remember the ABC that we spoke of. So in our MHSPC patients, that is metastatic hormone sensitive prostate cancer patients, we want to tackle A and C, not really so much of B. And for our MCRPC patients, we would want to tackle A plus B plus C and decrease the incidence of SREs. And what are SREs? Pathological bone fractures, spinal cord compression, orthopedic surgical intervention, and palliative RT to the bone. These are all very significant and very morbid things to happen to our patient. And if we have something that can reduce the incidence or prevent this, why should we not be using them? So we would want to give calcium and vitamin D supplements to all our patients. So any patient in whom you want to start androgen deprivation therapy, that patient has to be on calcium and vitamin D supplements. Would you want to give zoledronic acid also? That will depend on the DEXA scan. So what does zoledronic acid do? It inhibits osteoclast function. So you do the DEXA scan. On the DEXA scan, you will come to know whether your patient already has osteoporosis. Now, if the patient already has osteoporosis and you are going to induce more osteoporosis with your androgen deprivation and possibly also starting predni along with abiraterone, only calcium and vitamin D are not going to work. And that is why you need to give these patients zoledronic acid. Now for HSPC patients, that is your newly diagnosed metastatic prostate cancer patients, you don't have to give them monthly infusions. You have to give 5 mg infusion once a year. So it's a single infusion in a year. When later on the patient will become a CRPC patient, we need to give monthly infusions, and that time the dose is 4 mg. Some evidence also states that 3 months is not inferior to every month, but mostly it is given every month. Duration of therapy, there is no clear evidence. We usually go on for a year or about 2 years. A dental checkup is mandatory because osteonecrosis of the jaw is a well described but rare but very devastating side effect. And you should have a 2 to 3 week gap between dental extraction and initiating zoledronic acid. You would want to check renal function and want to give a slow infusion because zoledronic acid is renotoxic. Hypocalcemia is also one very common side effect. So you would want to keep the calcium levels being checked when zoledronic acid is being prescribed to the patient. Another option is to use denosumab 60 mg once every 6 months. So you can either use zoledronic acid 5 mg once a year or denosumab 60 mg once in 6 months. Denosumab is much more expensive than zoledronic acid, but it is a subcutaneous injection. It does not need a slow IV infusion. So we did ADT, we added abiraterone, we gave RT to the prostate, we said we would not be giving RT to the bone mets, and we prescribed calcium and vitamin D supplements to our patient. We ordered a DEXA scan, and then based on that DEXA scan, we decided whether we would also be wanting to give our patient zoledronic acid or not. Is there any other advice that we would want to give to our patient? We would want them to be active, right? Because again, testosterone is coming down in their body. So we would ask them to do weight-bearing exercises about 3 to 4 times a week for 30 to 40 minutes. We would want them to stop smoking if they are, and also reduce alcohol intake. So that completes about low volume metastatic prostate cancer. Now this is just another video. I hope you can see it run. And basically what I'm showing in the video is that there are a lot of bones which are lighting up on this PSMA PET scan. And this is no longer low volume disease. This patient has high volume metastatic prostate cancer. High volume disease, the definition was more than 4 bone mets, or more than 1 appendicular skeletal mets, or visceral mets. Visceral mets means lung mets or liver mets. Liver mets are more common than lung mets. So whatever we talked about till now was doublet therapy. Monotherapy was used initially 10 years back, only ADT. Doublet therapy is ADT plus something, and we saw plus what? We have options available. Now when we have more disease in the body, do we want to use more ammunition to kill it? Probably yes. So we would want to use 3 agents instead of 2. That is called as triplet therapy. What are the triplet options and what are the tolerance? We will see now. So this is one triplet option that we have. So we were using ADT plus abiraterone. We want to add docetaxel to it. This was the piece 1 trial that was reported. Again, the benefit was seen mostly in high volume patients, and that is why we did not speak of the triplet therapy in low volume patients. The hazards ratio was 0.75, which was significant, and that is why in high volume patients, if possible, we would want to use triplet. Obviously, with multiple agents comes more toxicity and also more financial aspect. Now, ADT plus darolutamide plus docetaxel is another option. Now, why didn't I talk about darolutamide when I spoke about low volume prostate cancer? Because just as we had trials about ADT plus abiraterone, ADT plus enzalutamide, ADT plus apalutamide, we don't have a trial for only ADT plus darolutamide versus ADT alone. The trial was ADT plus darolutamide plus docetaxel versus ADT alone. And that is why there is no evidence to use only ADT plus darolutamide, but there is evidence to use ADT plus darolutamide plus docetaxel in our high volume metastatic prostate cancer patients. This was the trial, Arasens. The dose of docetaxel is 600 mg once a day. Out of enza, apalutamide and darolutamide, our medical oncology colleagues tell us that darolutamide is the most well tolerated, but it is also the most expensive, 1.2 lakh rupees per month, and it is to be taken till disease progression. So this was our routine patient who had come to the OPD. If you remember, our patient was ECOG1. Now, what if the patient comes on a stretcher, right? So this is one thing which can happen once in a few months, especially in a general hospital. Here the concerns are there is loss of power or just pain and the duration of symptoms. So if somebody has come on a stretcher and the family says कि 10 दिन से पैर नहीं चल रहा है, then we've lost the window of doing anything for this patient's power and nothing can be done. But if the patient has come to you in an acute phase where the family is saying or the patient is saying that I have been losing power since a few hours or maybe since today morning, then there is something that we can do. What we need to do is in the casualty, give DEXA 10 mg, order for an urgent MRI spine to see what is happening, at what level it is happening, get an urgent neuro or an ortho referral done, start androgen deprivation for this patient. Now, if this patient has had a prostate biopsy report and you know that these are bone mets from the prostate, you can do an orchidectomy, because again, we were talking about a general patient, right? In the general hospital, might not afford the antagonist. But usually we would not want to do an orchidectomy if the pathology report of prostate cancer is not available, because it's an irreversible thing that we are doing for a patient. So in such a patient, we would want to give him antagonist, which is Degarelix. 2 brands are available. One is very expensive, one is not so expensive. If the patient cannot afford the not so expensive thing also, then one thing that you can give the patient is bicalutamide monotherapy. So bicalutamide is also an androgen receptor antagonist. It will stop all the testosterone in the body from acting. And when we work up this patient and do the biopsy, once the biopsy report is available, we can do the orchidectomy. So if the patient is affording, We give him the shot of antagonist right there, irrespective of whether the prostate biopsy report is available or not, because it is not an irreversible thing that you are doing. But if the patient is not affording and the only thing that you can do is an orchidectomy, you would do an orchidectomy only if the biopsy report is available. If the biopsy report is not available, one thing that you can do is bicalutamide 150 mg once a day till the biopsy report is available, just to halt the disease process. And obviously there is always guarded prognosis on limb recovery. Our patient, if you remember, also had the catheter. He had gone into retention. So now do tamsulosin, alfazocin,
Metastatic Ca Prostate CMH.
silodosin, do these act in these large cancerous prostates which have eaten up into that smooth muscle? Probably and probably not, but there is no harm in trying the alpha blockers, and hence we would want to give alpha blockers to our patients. We would not take all of them for a channel TUR. Would you give dutasteride also in them? So what does dutasteride do? Dutasteride inhibits the conversion of testosterone to DHT, dihydrotestosterone. Now there is no testosterone in the body because you've already made the patient castrate. Hence, there is probably no role of using dutasteride in your patient of metastatic prostate cancer with the aim that dutasteride will bring about shrinkage of the prostate gland. It's probably not going to work because testosterone is not there in the body to get converted to dihydrotestosterone. When do you give a voiding trial? Again, it is not like a black and white answer. We usually give it at 3 to 4 weeks. We allow that much time for the alpha blocker to act and the androgen deprivation to act. So all of that acts together. The prostate probably shrinks and the bladder neck opens up, and the voiding trial might get successful after 3 to 4 weeks. Channel TURP during chemotherapy. So if the patient has been started on chemotherapy, we would want to avoid doing a channel TUR, or probably take that 3-week window between 2 cycles of chemotherapy and do a quick channel TUR. Now, what if the patient also has hematuria? Does androgen deprivation therapy work? Yes, because androgen deprivation therapy is going to reduce the entire vascularity of the prostate gland. Will you do a TURP? You might want to do a TURP, a channel TURP, if the ADT alone is not helping with the hematuria. If your TURP is also not working, or if the patient cannot be worked up for a TURP or is not going to withstand a TURP, a thing that we can use is hemostatic RT. Completely non-invasive. Single sitting is done or 2 sittings are done, and we expect that the prostate stops bleeding around 24 to 48 to 72 hours after the hemostatic RT has been given. And even if that does not work, one thing that we can use is angioembolization. So this is usually the sequence of events that we try, from something very non-invasive to something invasive. For pain at metastatic site, we give palliative RT. We give it at 8 to 10 grays. We can give at multiple sites. It takes a couple of days again for the benefit to come, and it can be repeated at the same site again if the cancer starts growing there. So this is all about treatment, but the patient and the family wants to know ki kya hone wala hai? How long is the patient going to live? So we have to have that tough discussion with our patient, because we know that our patient is not curative intent. It is palliative intent treatment that we are doing, and we need to counsel the patient about prognosis. So we need to discuss about how long will the patient live. Can we predict how long will the patient live? And do we have better prediction after we've started the treatment? So the HSPC prognosis depends upon the volume or burden of disease. And we have seen this. Low volume patients do better than high volume patients. It also depends upon the PSA response. So once you start therapy, we see the PSA after 7 months of starting ADT. And these are the responses. If we see this response, this is how much we estimate the patient to live. Now this paper was written in 2004. At that time, only ADT was available. Abiraterone, docetaxel were not being used. So we are expecting that the survivals will be much higher compared to what it was in this paper. But this is what is written in the guidelines even today. So in 2005, when we had ADT alone, patients used to live for a median of 2 years. In 2016, again with ADT alone, patients used to live for 45 months. Why? Because after they failed on ADT, we had docetaxel available. We had abiraterone available. These agents were approved for the CRPC setting. They were not available in 2005. So in 2005, when the patient failed on ADT, all that we could give the patient was probably Honovan. But in 2016, we could give the patient much more. And that is why these patients lived for close to 4 years. When we added docetaxel, the OS has gone up to 5 years. When we've added abiraterone, the survival has gone up to 79 months. This is what the paper says. 79 months is close to 6 to 7 years. That is a very long time for somebody with metastatic cancer to live with. And that is why metastatic prostate cancer is one of the best metastatic cancers to probably have. And that is why we need to tell our patients and our families that all is not lost. We have a lot of therapies available. If the patient can tolerate them and if the family can afford them, we can definitely pull on for multiple years. It is just that in our clinics, we see that our patients don't live so long, and they might, live a year or two less than what the papers actually say. And obviously the papers always, every paper has well-selected patients, and patients in the clinical setting in the OPD do much worse than patients in the papers. One last thing, do we want to do a genetic evaluation in our 71-year-old patient? Guidelines say that you should do it in all. So should we do it in all metastatic patients? What are we looking for? Where to get it done? What is the cost? What are the implications for management? We'll see all this. So we ask our patients, family mein kisi ko cancer hai kya? Now that is a very weird question to ask. So what is a positive family history? This is the first definition of a positive family history. A strong family history of prostate cancer means either the brother or the father or multiple family members had prostate cancer, not a Gleason 6, but something more aggressive, at less than 60 years of age, or they died from prostate cancer. So if somebody's father had a prostate cancer of Gleason 7, but diagnosed at the age of 79, this patient does not have a positive family history. Okay, so this is what we need to know. Multiple members having prostate cancer, significant prostate cancer, and also at a much younger age. Then we would think that probably this patient might be having a positive family history. Or the second definition is that you have 3 or more cancers on the same side of the family diagnosed at again less age. And that is why you need to ask patients for any family history of prostate cancer, breast cancer, colon cancer, because this is all encompassed by BRCA, which is the most common mutation that we see in our mutated prostate cancer patients. So why do we perform a genetic testing? Because 1 out of 8 men, it is shown in literature, but in our clinical setting it's not so common. 1 out of 8 men may have the DNA repair mutations. It can guide screening for secondary cancers, and we might want to then screen the family members also. Guidelines say that you do it for all metastatic prostate cancer patients. In the clinic, we don't have the facilities available, or the patients have the finances available for genetic testing in all our patients, so we don't do it. We do it only in patients who are very young or who have a very significant family history. Is it still going to impact their treatment? Not now when we start treatment, but probably when they become CRPC. If we have found a genetic mutation, there are a couple of agents available which we may want to use in them later on when they become CRPC. What if our patient was 90 instead of 71? We would have probably done watchful waiting for him. We would have only taken care of his catheter and his symptoms and not chased his prostate cancer too much. Would we have done ADT alone? Now, there are a lot of people who say that ADT alone is the worst thing that you can do for a patient because it causes a lot of side effects. But ADT alone is probably something that you might choose for a 90-year-old patient, expecting that he does not have a long to live, does not have a long to experience the side effects, and is something which he can easily afford. Abiraterone and enzalutamide are still 2 tablets, right? It is not chemotherapy. A 90-year-old ECOG 0 or an ECOG 1 patient may still be eligible to take those 2 tablets. How do you follow up these patients? How often? Only PSA. So how often? We see our patients every 3 months. We see them with a PSA only in the beginning. We see them with multiple blood reports like CBC, RFTs, LFTs, and electrolytes and lipid profiles. We would do a PSMA PET scan only if the PSA is rising. Otherwise, we are not doing the PET scan. If somebody had a 5+5, or if somebody was a PSA non-secretor in whom I cannot trust the PSA, or if somebody had a considerable proportion of a neuroendocrine component, in that patient, I would probably not wait for a PSA rise to occur to trigger the PET scan. I would probably just order a PET scan without the PSA also rising. What is the usual time for a patient to become CRPC? Again, there is no definite answer, but usually around 2 years is when most of your patients, 2 to 3 years is most of your patients would start seeing a rise in PSA. So to summarize, we saw that biopsy, yes, we have to do a biopsy in all our patients who have florid mets on the PET scan, because as of now we have to. Probably in the future we might not do a biopsy. We do the PSA PET scan and risk stratify our patients into low volume versus high volume. We need to counsel the family about the treatment plan and the likely prognosis. Start androgen deprivation therapy, use any of these three options, and we saw how to choose what to use when. We need to choose one of these 4 or 5 agents for the add-on therapy. We can use a triplet for high volume patients. We would want to give RT to the prostate for our low volume patients. Calcium and vitamin D supplements for all patients. Emphasize on physical activity for all patients. We would do a DEXA scan for all patients and only then decide whether we want to give zoledronic acid or not. Manage the catheter, use alpha blockers or do a channel TURP. We saw how to manage pain. Intractable pain, probably give palliative radiation therapy. Intractable hematuria, probably give hemostatic RT or angioembolization. We saw how to manage paraparesis if it's an acute onset event. And also discuss about genetic testing only in patients who have a strong family history. And we saw what we mean by a strong family history. Yeah. Thank you so much. I'm
Thank
not
you,
going to
Amandeep.
ARPC because that will probably take another half an hour or something. So HSPC for an hour probably, yes.
Yeah, I think that is okay. Thank you so much, Amandeep.
Thank you so much, sir.
It was a very nice presentation. So I guess everybody would have learned a lot from this. And if we have to go ahead with the case now, it's over to Gaurang Shah, sir.
Yeah. So Amandeep, if you have got some case you can discuss, or we have got one case, we'll just go through the history fast, and the findings you can just ask there are 3 students who are answering.
Sure, sir.
So whatever you have taught them, I'm sure that they will be able to answer. Okay.
Sure,
So
sir.
Brijesh, can you start your screen?
Yes, sir.
Yeah. So Amandeep, as usual, it is the one of the fantastic presentation I have come across, and after listening to second time, I realized that I was not knowing so many things. Now I understand it. Thank you.
Thank you so much, sir.
Okay, so who 3 are answering?
Good evening, sir. I am answering, sir. Name is Sriram.
Sir, me,
Sriram, na?
Rupam, sir.
Yes.
Rupam.
Yes, sir.
Rupam is answering, Sriram is answering, and Miraj is answering, right?
Gaurang Shah, sir, will also take Bakshi sir and Mahendra sir to ask some questions.
Yeah. They are already there.
Yeah. Okay.
If nobody answers, I will answer.
Amandeep, you will not feel alone. We are here.
Okay, fine. So Brijesh, start it.
Yes.
Tell the full history fast.
Yeah, 72-year-old male came with a complaint of increased frequency of urine since 3 months, decreased urinary flow in 2 months, and back pain since 1 month.
Go ahead.
So patient was asymptomatic before 3 months. Then he had started lower urinary tract symptoms. FUNP score has been mentioned, and he also had a dull aching back pain since 1 month. It was non-radiating and was aggravated on mobilization and relieved on taking rest and medications. He had a negative history of burning mucus and hematuria, no colic pain, no instrumentations, no weight loss, no bleeding disorders, no chemotherapy or no any radiation therapy in the past. He was an hypertensive patient. He was taking bisoprolol and telmisartan since 10 years. No any previous surgeries, no any significant family history, and he was having no any bad habits or any non-smoker and non-alcoholic. The general examination was normal, and neurological examination was also normal. There was no any weakness, motor and sensory. Both examinations were normal, no any tingling, numbness, or any specific neurological point of view. Local examination was also normal. On digital rectal examination, there was grade 2 prostatic enlargement, and there was slightly hard prostate with right lobe likely to be adherent with rectal mucosa. And on clinical examination over the spine region, patient had mild tenderness over lumbar and sacral areas of the spine. Rest everything was normal.
Okay, Brijesh. So can we just summarize what was the age of the patient?
72 years.
Okay, so you have a 72-year-old hypertensive on 3 medications who has lower urinary tract symptoms, right? That is his only complaint.
And back pain.
Back pain, and you found some spinal tenderness, and you've also found a hard prostate with some infiltration into the rectum. Some rectal mucus are not moving.
Yes.
Okay, so what is the clinical diagnosis? What are you thinking on the lines of?
Sir, our clinical diagnosis will be Ca prostate, sir.
Okay, so at the
First
end of
diagnosis.
history, probably BPH was also one of the differentials because we only had LUTs, and back pain can be because of a lot of things. But now once we have done the examination, it is not because of the spinal tenderness, but because of the hard nodular prostate that you have felt.
Yes, sir.
Probably there is just one diagnosis that you're thinking of right now, right? I am not very good, okay, with giving differentials for an exam case because it's been some time since I've done that. But in this case, we are mostly looking at prostate cancer, right? As our first diagnosis.
Yes, sir.
So we've examined our patient also, and that is our working diagnosis. What is the next thing that you want to do for the patient?
Sir, we'll go
Ultrasound
for
and
some blood
serum PSA.
investigations.
Okay.
PSA.
Okay, so we've done our routine blood investigations and the PSA, right? What are the routine blood investigations that you're doing?
Sir, complete blood count, the renal panel, and the LFT. Then urine routine examination. Then serum PSA. And sir, vitamin D.
Okay, always do the coag profile in your patients, okay? Because you're definitely going to biopsy this patient, okay? And always check the sugars because you would not want to do a biopsy with uncontrolled sugars, okay?
Yes, sir.
All right. So what is the PSA? We are assuming everything else is normal. What is the PSA?
By Brijesh.
Okay, so we have a very high PSA. Okay, and we have a slightly raised alk phos also. Okay, do we have the urine report?
Yes.
Okay, we see innumerable pus cells. Okay, are you trusting that 94 PSA, Brijesh? Or do you think it is falsely elevated because of a UTI?
It's our
It might
differential
be so.
diagnosis.
Sorry?
94 will not be.
Yeah, anyone just say it out.
Sir, yeah, it might be due to
Prostatitis is one of the
infections.
cause of the
Prostatitis, yeah.
Yeah,
maybe
okay.
one.
So you could have UTI, you could have prostatitis. So if your DRE finding was not that classical, these could have been the differentials also, right? After these reports.
Yes, sir.
Yes, sir.
Yes, sir.
Still, 94 is a little too high. It was in the 20s or the 30s or in the 10s.
30s.
We would have probably assumed that the PSA could be falsely high if our DRE was normal
Yes, sir.
or not very classical, and we would have wanted to treat this UTI, right? And then repeat the PSA. When would you repeat the PSA after treating a UTI?
Sir, after 4 weeks.
Yeah, the half-life of PSA is 5 to 7 days.
5 to 7 days.
You want to allow the PSA to fall and come back to a value, okay? But with somebody with that classical finding or with the PSA of 94, we are not doubting whether this is because of a UTI or not, even though your patient might have a concomitant UTI.
Yes, sir.
Okay? Would you want to treat this UTI before proceeding?
Yes, sir. Definitely, we have to treat the UTI, sir.
Why?
Because we are planning for an intervention for this patient.
Correct. And you're
If
planning
we
for
plan for a prostate biopsy, we should treat the infection first if there is any coexisting infection.
Yes, exactly. So you would want to treat this patient with either oral or IV antibiotics. When you see this urine report, would you also want to find out why this patient has UTI and what else would you want to do to find this out? He has voiding symptoms. He's not voiding well. He has a UTI. You want to know what is his PVR?
Yes, sir. In ultrasonography, we can find out about the post-void residual urine also.
Exactly.
That may lead to
Yes, sir.
Yes, right. So you would want to know whether his PVR is high or not, right? And if
Yes,
PVR
yes,
is very high, without treating that high PVR, there is no way you are getting rid of the UTI. And with a very high PVR, you would again risk doing a biopsy,
yes, sir.
right? So you have to fine tune, try to catheterize him if you feel that it's a very high PVR which might not settle on its own with alpha blockers. Treat the UTI with some antibiotics, and then what do you want to do? So you're treating the infection. What is the next investigation that you want to do to chase his PSA?
Sir, we'll go
MRI.
for MRI, MP MRI.
MP MRI.
Okay.
Before going for a biopsy.
Okay. What do you think this patient would have with a 94 PSA? What?
तो अभी खिलाएगी ना 7 मिनट तो होगा.
Sorry. So are we looking at localized T3 kind of prostate cancer or something much more advanced?
Sir, more advanced. Sir.
More advanced, right? With a 94 PSA.
Yes. 94 PSA.
Yeah. So I'm not saying that 100% of this patient has metastatic prostate cancer. I'm saying there are more chances that this patient has a metastatic prostate cancer. If you want to do an MRI before doing the biopsy, I would not say that you are wrong. But that MRI, there are more chances that MRI is going to be useless. Okay.
Yes, sir.
So if you want to justify that MRI, you can say this, that there is a small chance that he may not be metastatic, and then I don't want to wait for 4 weeks later to do the MRI. Hence, I want to do it right now. It is easily available. It is not very expensive. If you want to say you don't want to do the MRI, you need to know how to justify that answer as well, right? And then you will see that you are mostly thinking on lines for metastatic prostate cancer with that higher PSA. And you already kind of know that the rectal mucosa is not moving. The MRI is not going to add too much, right? Because you don't want to see targets inside because your gland is hard. So the MRI is mostly not adding too much to what information you already have from the clinical examination, and the MRI might be redundant in this patient. Okay, so you can defend both ways. If I have to give one answer, I would say I'm not doing the MRI in this patient, and I'm straight doing the biopsy.
Yes, sir.
Okay, all right.
Yes,
so what kind of biopsy do you want to do?
Sir, trans-guided biopsy we ideally prefer.
Okay, so some centers have started doing transperineal biopsy. They say that the risk of infection with transperineal biopsy is close to 0. But the risk of an infection with transrectal biopsy is not very high. Some studies say there's a significant difference. Some studies say there is no significant difference. The European guidelines say that you should do a transperineal biopsy if the facilities are available. And some countries say that doing a transrectal biopsy is doing disservice to your patients. You should only do transperineal biopsies. The NCCN guidelines and the American Association of Urology guidelines say that there is no clear evidence available as of yet to say that transperineal biopsy is better than transrectal biopsy. So you can say any of the two, just know how to defend it. If your center does transrectal biopsy, very good. Even Tata Hospital does transrectal biopsies only. Okay, in some patients, we have started doing transperineal biopsies for apically located lesions because they are not well targeted on transrectal biopsies. But 9 out of 10 patients in Tata Hospital also undergo transrectal biopsy. Okay. How many cores do you want to take?
So 12 core biopsy.
Okay. So for this patient with a hard prostate, 12 cores or even lesser cores is fine. Okay.
Yeah.
Do we have the biopsy report?
Okay. Patient lost the follow-up and came after 1 month with a TR biopsy report out from the outside. So we could see it was acinar adenocarcinoma with lesions 5+4. Okay.
So he basically probably underwent a channel TR outside, right?
Yes.
This is what is shown here. Okay, so it's good for him. His LUTs have gone, his PVR has gone, his infection has probably gone, UTI has gone, but we found this cancer. Okay, now what? What is the next thing that you want to do? So now you have a patient with prostate cancer with Gleason 9 and a PSA of 94. What next?
To stage the
So we'll
disease.
go for a metastatic workup.
PSM. PSM.
Right, because we want to stage the disease.
Stage the disease.
Okay, Amandeep, I will just interfere here. The patient came also with MRI. So your question was that whether we should do MRI or not in this patient. Brijesh, just show them MRI so that students will come to know whether it is useful or not.
Yeah.
Read the
This was
report.
the prostatic, yeah. There is evidence of lobulated heterogeneous T2 hypertensive lesion seen in the mid and the apex regions of residual prostate involving peripheral transit zones. Appears hyperintense on T1 weighted images and prostatic patchy of restricted diffusion with corresponding hypointensive on ADC images.
Okay. So we can see on the images that the rectum is probably infiltrated at one place.
Yeah.
So
overall, it was saying T1 weighted hyperintense and heterogeneously T2 hyperintense focal lesions in left half of the residual prostate gland involving mid and apex of the gland with extensive adjacent periprostatic space abutting the rectum and also involvement of right seminal vesicles.
Okay. So we've got to know the T stage of this cancer, right?
T3B.
Yeah. And the T stage is probably not very important if our PET scan
T4.
shows something. If the PET scan says it is if it is N0 and M0, then this T stage becomes very important, right?
Yes, sir.
Okay. So did we go ahead and do the PET scan?
Brijesh, show them.
Yeah.
PET scan was having significant periprostatic standings and enlarged presacral and bilateral internal iliac.
M1.
Okay. So
And,
fine, we won't read the entire report.
Yes.
We are seeing that there is uptake in the prostate, which we know. We are seeing that there are localized lymph nodes. We are seeing there are non-regional lymph nodes. We are seeing there is bone mets. And we are, okay. But we are not seeing any visceral mets. Okay. So what is the M staging of our patient?
M1B.
M1B. Right. So our patient has T3B/T4 because of rectum. N1 because it's either N0 or N1. M1B, prostate cancer. Right?
Yes, sir.
Okay. You initially 1 month back he had that spine tenderness also. What has happened to that? Do we have any idea? In 1 month? Because he has a lot of bone mets. Okay, if you don't have any info, it is fine. It's okay. So is this the end of the presentation? I mean, is that all that we have? Rajesh?
Yeah, yes, sir. Just we have treated the patient with because patient was having more lower urinary symptoms and
Correct.
his prostatic that uroflowmetry was also weak, suggested of outlet obstruction. So already went channel TRP orchidectomy.
Okay. So now what is your line of management for this patient? So your patient has metastatic prostate cancer?
Yes, sir.
Yeah.
Yes. Is it hormone sensitive or hormone refractory?
Hormone sensitive. It's not
But
been
it's
treated.
correct.
Not
Now in
Hormone
hormone
sensitive.
sensitive we have two varieties we saw as per charted.
Low volume and high
Yes, sir.
volume.
High volume and low volume.
So
This
our
is
patient
high
So
volume.
this high volume, sir.
High volume.
Okay, so our patient has high
More
volume
than 4
hormone
bone mets.
sensitive metastatic prostate cancer. Okay.
Yes.
What's the first thing that we want to do for our patient?
Sir, we have to ask him androgen deprivation therapy. We should go for, sir.
Correct.
Yes, sir.
So has that already been
We'll
done for this patient?
we'll give the option of orchidectomy or either ADT.
ADT.
Oh, sorry, androgen.
Yeah, so don't say ADT, either orchidectomy.
No, sir, yeah.
Because orchidectomy is
NSR is agonist or antagonist.
Yeah, yeah. Okay. Right. Okay, and you know what all you're going to tell the patient? Because the patient is going to ask you, "आप बताओ कौन सा बेहतर है," right? So then you are going to tell the patient which option is better. You will say the plus and the minus points and help him choose. Okay.
Yes.
So let's assume that we did an orchidectomy for the patient. Okay, because he was not very affordable. What next? What next do you want to do for the patient?
Sir, we can either go for chemotherapy option or
Okay.
we can add
Add
abiraterone.
abiraterone.
Okay. So is it either or it can be both?
Can be both, sir.
Right. Why?
So there has been trials that proving docetaxel plus abiraterone is more helpful than docetaxel alone, sir.
In which category of patients?
CRPC.
Or CRPC, sir.
So we just saw the Peace 1 trial, right, in the presentation.
Yeah.
We saw the triplet therapy. And we said that triplet therapy has shown survival benefit only in high volume metastatic prostate cancer. And our patient is high volume metastatic prostate cancer. So in our patient, instead of using doublet therapy, that is either docetaxel or abiraterone along with the orchidectomy, if the patient is fit to receive the chemotherapy, we would want to give him ADT, which we have done, plus docetaxel, plus abiraterone. Does that make sense?
Yes, sir.
If you are not understanding or if you have not understood why we are talking of triplet therapy, please tell me. I'll say it again.
Sir, high volume disease, we can go for triplet therapy.
Exactly. So our patient has high volume disease, and high volume disease, the first choice is triplet therapy. If the patient can tolerate it, if the family can afford it. Okay. If our patient cannot take it, then we would give
Monotherapy.
monotherapy and in
Monotherapy with bicalutamide.
Okay. So if our patient has money for one of the two agents, what would you choose from docetaxel and abiraterone?
Abiraterone, sir, he is hypertensive.
Hypertensive.
Yeah, so he has 3 tablets going on, right? So I like this that you are thinking about the patient as a whole and not only the disease. So he has 3 antihypertensive medications going on. We would want to speak to his physician and understand whether he can be given abiraterone, which is going to cause fluid overload in him. Correct? And if the physician says that fine, you can safely give abiraterone, then we would want to give abiraterone because it is better tolerated than cytotoxic chemotherapy, which is docetaxel. Okay. You said give bicalutamide monotherapy. We would give it only if nothing else can be given.
Yes, sir.
Okay. So we did orchidectomy for our patient. We have started him on triplet therapy. If not triplet, at least the doublet with abiraterone. ADT plus docetaxel only is usually not used nowadays. Okay. It is either ADT plus docetaxel plus abiraterone or ADT plus abiraterone. ADT plus docetaxel is usually not used nowadays. Okay, because docetaxel performs a little less than abiraterone, and abiraterone nowadays, a lot of generic compounds are available, so it is not very, very expensive, and most of the patients can afford it.
Yes, sir.
Okay, so we've done the orchidectomy, we've started abiraterone also for the patient. What do we tell the patient when to come back next?
Sir, after 3 months, we will do repeat PSA.
Okay. Do we send the patient off with some more advice?
So bone health, we
Yes,
have to
sir.
also see about
Calcium, vitamin D.
calcium and vitamin D supplements are necessary.
Supplements.
And we are first doing the DEXA scan, right? Don't forget that.
DEXA scan, sir. Yes, sir.
We are always doing a DEXA scan. Okay, we are giving calcium
Yes.
and vitamin D, but we are doing the DEXA scan to find out if we also need to add zoledronic acid for our patient.
Zoledronic acid. Yes.
Okay. And then we take care of his back pain also if he still has
Back
it.
pain.
Okay. We are expecting that with the orchidectomy and the abiraterone and the calcium and vitamin D, his back pain will improve. Okay. And then we are calling him after 3 months with a PSA. Suppose he comes back with a PSA of 4. Is that good or is that bad? Yeah, so to fall from 94 to 4 is good. Okay.
Good.
But patients with the best is, come back to something near 0 or something to 1. Okay. So 4 is not excellent, but 4 is very good. Okay. So there is no yes or no answer for this. What investigations apart from PSA are you doing at the 3-month follow-up?
Serum calcium, serum creatinine, lipid profile will do. And if you are started on abiraterone, we'll also monitor his liver function test, sir.
And the electrolytes, because
And electrolytes.
Water retention, hypoglycemia, correct?
Yes. Yes.
And sugars also.
Sugars, sir.
And you're asking the patient to keep a track on his blood pressure at home for 3 months.
Yes. Yes.
Right? So
Yes.
all of this is comprehensive management of the patient.
Yes,
Right?
sir. Yes, sir.
Okay. Sir, it is around 10:40. What do we do? Mahendra sir, Bakshi sir, if you want to ask anything to them.
No, I think most of the things are the same which you had in the presentation. So maybe if there is any more questions to anybody, let us just answer that.
Yeah, if
rather
somebody
than
has any questions, maybe, yeah, if they've written in the chat box, but we've not answered them, anybody
maybe
can go ahead and ask
take
some.
that.
So a slide you had shown of abiraterone and docetaxel together, that one part. Could you just show that again? That was a little confusing, sir.
So one question I can ask is, when will you start enzalutamide with ADT in MCSP? Which patient you will technically select?
So we, so this answer that I'm giving you is coming from discussion or what I've heard from our medical oncology colleagues, and they say that usually they would want to give enzalutamide to somebody who cannot take abiraterone.
Amandeep students ke liye.
Yes, yes, sir. So basically, what I'm saying is what I am saying as the answer. Acha, you are asking the students. Okay, I'm sorry.
Patient with hypertension.
Uncontrolled hypertension.
Sir, enzalutamide crosses blood-brain barrier. So if the patient has cognitive disorder, we should not go for enzalutamide.
Correct. So those are the patients with seizures or cognitive brain disorders who don't use enzalutamide. So I just asked you the other way around, which patient will use enzalutamide?
Sir, apalutamide is good. That doesn't cross blood-brain barrier.
Patient with hypertension.
Okay. So usually, as Dr. Amandeep told you, we start abiraterone or docetaxel. Now, if you have contraindications to these two drugs and no study trial wise exclusion criteria of enzalutamide, then you would have to probably consider enzalutamide. Suppose if somebody has, say, hypertension and high blood sugar, not so well controlled, that patient will go for an enzalutamide. These patients can also go to apalutamide as per the Titan study. But apalutamide currently is slightly expensive. I would rather start enzalutamide, wait. If the patient shows some side effects of enzalutamide, like one of the side effects is fatigue and extreme fatigue, which can happen with enzalutamide. If patient complains of that at 3 months, Dr. Amandeep was asking that question, what will you do at with respect to many things, including your bloods and such things which may be potential side effects of each of those drugs which you have started beginning. If that patient on enzalutamide comes and I have tremendous fatigue, I have started resting, sleeping, etc. Might change much lesser. Okay, we are seeing something else. There was a question just put in the chat. Could we stop? No, live. Can we stop? So ideally, in metastatic prostate cancer, hormone therapy. Dr. Amandeep has said that in very specific indication for an intermittent androgen therapy. It is also a continuous therapy. Can we stop people at any time? So, not definitely continue. It cannot be stopped unless there is some cross problem. So, like, side effect profile, which quite long. Some of the agonist has includes something like developing CKD also. switch over to something different. ये slide किसको देखना था? Which Dr. Amandeep?
So I wanted to see, sir.
हो गया देखे कि कुछ
Yes, sir.
कर रहा है.
Yes, sir. Thank you.
So any more questions if anybody please?
Yeah. Dr. Maheshwari, Dr. Balaji, I mean Gite sir, Mahendra, if you have got any question, you can ask the
No,
student. But
the one question that somebody asked when luprat can be started. So like that, luprat can be started if patient opts for surgical castration. Then you can stop ADT, because two modes of ADT is not recommended. ADT antagonist all. So only one type is to be given. Only that condition luprat can be stopped. So it's a tricky question. I think you may say which condition luprat can be stopped. Only thing that you want surgical castration. Then no medical castration.
And please remember, after bilateral orchidectomy done, you don't need to add lupride or decarylix or elugolix or anything to any patient. We see patients at least 4 to 10 times a year where clinicians have started after bilateral orchidectomy on some PSA progression, again, luprolide or palmorelin or whatever, decarylix. It is absurd.
yeah, good point.
Sir, I don't think there's any more question in the chat.
Yeah, because
one more thing, other than the DEXA scan, I think I also wrote in the chat box that FRAX score is there. FRAX score is available online, which the country-wise, the race-wise chances of fracture it can calculate. So like that, the other method other than DEXA scan, the FRAX scoring for bone health.
Yes. And where it is available?
It's online, sir. It's available online. They will ask your origin of country, like Africa, India, anywhere. They have that some database. So based on that, your origin of country, they have this certification. So they will give how much based on your criteria, how much risk factor of a bone event you have. FRAX, FRAX.
I think in the talk only he had covered almost everything with the case presentation. And so that is the reason this about case became so easy for the students to answer. So Amandeep, this is going to remain forever. Okay, your lecture on YouTube. And you believe me, whenever you go across the India, some student will come and tell you, thank you very much. We benefited too much from your. So thank you very much for taking our invitation and helping our students. Not only students, I think many consultants also had.
Thank you for this opportunity, sir. Thank you so much.
Excellent, good, Amandeep. Excellent, good.
Thank you, sir.
Okay.
We say good night.
Yes, good night. Thank you, Ganesh, for arranging this lecture.
Good night, sir.
Good night.
Good night.